This is Michelle. Michelle is 22 years old, and she is currently out shopping at her local grocery store. She's thinking about a lot of different things going on in her life and trying to make sure she buys everything she needs at the same time. When she goes to check the price on a can of pasta sauce, she notices something is happening to her. Her heart starts pounding and she can feel it in her throat. She feels her hand tingling and starts to notice that her arm is shaking. She has no idea what is happening to her. All of the possible illnesses that she could possibly have start going through her head. Is she having a heart attack? Is this some sort of allergic reaction to a food she ate? Is this a stroke? Her chest pains are getting worse and she feels faint. She glances around and starts to feel even dizzier. She decides that she should walk outside of the store and leaves her cart behind. Once she gets outside, she feels major relief, but her symptoms are still not gone. She feels dizzy, faint, and sweaty. She decides that the best thing to do is to call her boyfriend so that he can take her to the hospital. While she waits for her results, she's still very concerned. When she hears that there is nothing physically wrong, she is relieved, but she also doesn't really understand. The doctor says that she had a panic attack. A panic attack, she thinks? What does that even mean? And does that mean she is going to have another one? The DSM-4 describes a panic attack as a discrete period of intense fear or discomfort in which 4 or more of the following symptoms develop abruptly and reach a peak within 10 minutes. Palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or smothering, feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, derealization, feelings of unreality or depersonalization, being detached from oneself, fear of losing control or going crazy, fear of dying, paresthesias, numbing or tingling sensations, and chills or hot flushes. Clearly, what Michelle experienced was a panic attack. However, approximately 8 to 12% of the population has an occasional unexpected panic attack, and most of these people do not develop anxiety. We would need to know more about Michelle to decide whether or not she in fact has or might develop a panic disorder. The DSM-4 characterizes the criteria for panic disorder as recurrent unexpected panic attacks. At least one of the attacks has been followed by 1 month or more of one or more of the following: persistent concern about having additional attacks, worry about the implications of the attack or its consequences, such as losing control, having a heart attack, going crazy, a significant change in behavior related to the attacks. The panic attacks are not due to the direct physiological effects of a substance, such as drug abuse or medication, or a general medical condition, such as hyperthyroidism. The panic attacks are not better accounted for by another mental disorder, such as social phobia, specific phobia, obsessive-compulsive disorder, post-traumatic stress disorder, or separation anxiety disorder. So, what causes someone who has a panic attack to develop a panic disorder? It is likely that panic disorder is related to biological and physiological factors and how these factors interact. If a person is vulnerable to stress, they may tend to overreact to some of the events of daily life. These same people may also have high blood pressure or headaches when they respond to stress. If certain situations, such as grocery shopping or riding an elevator, tend to cause a person to have panic attacks, this situation may become a conditioned stimulus for future panic attacks due to the internal and external cues that the person recognizes. The person must therefore also be susceptible to developing anxiety about having another attack. In other words, they must think that what their body is experiencing is dangerous and might possibly lead to something worse. Instead of attributing their panic attack to the events of the day or the moment, such as a bad date or being late to a meeting, they decide that the attack is due to something more severe. They are unable to cognitively process their anxiety in realistic terms, and consequently, they cause themselves more anxiety. For this reason, panic disorder may often lead to other conditions, such as depression or alcoholism. It may also lead to the development of phobias, which might develop in the place where the panic attack usually strikes. For example, Michelle might develop a fear of grocery shopping or handling food items, due to the fact that this was where her panic attack occurred. Sometimes the anxiety and panic are combined with such a strong desire to evade these phobias or unsafe situations that the person starts to avoid any places or situations from which escape might be difficult in the event of a panic attack. Because they never know when their attack will occur, they avoid many situations involving interaction or public spaces. Thus, the person develops agoraphobia with their panic disorder. For some people, this means never leaving their home for years on end, with or without the occurrence of another attack. And for others, this means enduring social interaction and public involvement with serious distress, often accompanied by some method of coping, such as alcohol or drugs. However, not all people with panic disorder develop agoraphobia, and it is also possible to develop agoraphobia without a history of panic disorder, although it is much less common. Approximately 2.7% of the population meet criteria for panic disorder or panic disorder with agoraphobia during a given one-year period, with 4.7% meeting them at some point in their lives. 2/3 of the people with the disorder are women, and the onset of the disorder is usually in early adult life, with the initial panic attacks occurring at or after puberty. It's possible that women report their fear more than men, who might be expected to act tougher. However, men still suffer from the disorder, and it is very possible that they are more likely to cope using alcohol, since they cannot express their phobias openly. So how should this disorder be treated? There are currently several treatments available for panic disorder, including both medication and psychological treatments, separately and combined. The goal of treatment is to help the individual function well in their everyday life, not necessarily to make the disorder go away. The most commonly prescribed drugs for panic disorders are serotonin reuptake inhibitors, SSRIs, such as Prozac, Zoloft, and Paxil. As seen here, these drugs work to enhance the effects of serotonin by preventing it from being absorbed in the synapse. Serotonin is a neurotransmitter involved in the regulation of behavior, moods, and thought processes. Extremely low levels of serotonin are associated with less inhibition and with instability. So these drugs ensure that there is enough serotonin in the system to regulate these dysfunctions. Other similar drugs that are used are serotonin norepinephrine reuptake inhibitors, SNRIs, such as venlafaxine, which function similarly. Other drugs which may be prescribed are high-potency benzodiazepines, such as Xanax, Valium, Klonopin, or Ativan, for a short time. They are known as central nervous system depressants because they introduce chemicals into the brain that enhance the production of GABA by making it easier for the molecules to attach themselves to specialized neuron receptors. GABA is a neurotransmitter that is known to reduce anxiety due to the fact that it reduces postsynaptic activity. While these drugs may work quickly to calm the patient down and reduce the physical effects of a panic attack, they are not recommended due to the fact that they often lead to physical and psychological dependence. They may even affect cognitive and motor functions negatively to some extent. About 60% of people with panic disorder who stay on effective drug treatment are free of their panic attacks. However, more than 20% generally stop taking the drug before treatment is complete, and the rate of relapse is almost 50%. This relapse rate is closer to 90% for those who take the benzodiazepines due to their high dependency. It is therefore not surprising that many patients try other forms of treatment, such as psychological intervention. Cognitive behavioral therapy is commonly used for patients with panic disorders. During therapy, the patients learn how to understand and control distorted views of life stressors, such as other people's behavior or life events, recognize and replace panic-causing thoughts and decrease the sense of helplessness, manage stress and relax when symptoms occur, imagine the things that cause the anxiety, starting with the least fearful, and practice in the real-life situation to help them overcome their fears. Gradual exposure treatments are also common, and are often paired with the relaxation techniques mentioned. Almost 70% of patients have a substantial improvement, and their anxiety and panic attacks are reduced. It is also helpful for those with agoraphobia. Recently, a new treatment called Panic Control Treatment, or PCT, has been developed. During this treatment, patients are exposed to many physical sensations that remind them of their panic attacks, sort of like a mini attack. They then use the techniques from cognitive behavioral therapy to change the individual's attitudes and perceptions about the attack, so that they are better able to control their panic. Studies have shown that 2 years after treatment, patients who use PCT remain better, but these treatments are still relatively new and therefore not always available. As with most things, it is also recommended by doctors that the person eats healthy and at regular times, as well as exercising regularly, and avoiding products that have a lot of caffeine, such as soda and coffee. While panic disorders may be long-lasting and hard to treat, many people with this disorder may be cured with a combination of support groups, cognitive behavioral therapy, and medications. Generally, a combination of treatments works well, although some of the drugs may interfere with the effects of psychological treatments. The most important thing is that the patient realizes he or she is not alone and has a support system to help them through the treatment process.